select all that apply. So iron repletion therapies. Probably not likely, right? Okay. So in terms of when we're looking at anemia in cancer patients, I'm going to be worried about increased destruction of RBCs, right? So that's usually when the chemotherapy is destroying circulating blood cells. I'm going to worry about decreased production of RBCs, and that's really what we call bone marrow suppression. So when chemotherapy is damaging bone marrow, it makes it a lot harder for the body to create these mature cells and allow them to migrate out to the periphery to support a patient's platelet function and red blood cells. And also loss of red blood cells. So we know that cancer patients can have a whole bunch of reasons for having blood loss, right? They can have had a major surgery that would require removal of organs maybe, or substantial amounts of tissue. We know that tumors themselves are often what's called friable, and that means that they bleed really easily. We also know that, patients, even if they don't have cancer of the colon, people get hemorrhoids and you can have a slow leak, or people can have GI bleeds and have a slow leak. So there are a variety of reasons why people might be dealing with blood loss. Another thing that's not minimal, usually not a huge problem, is that patients tend to have frequent blood draws needed. So, if you're on a weekly chemotherapy regimen, for example, which is not uncommon, then you're going to be having blood draws pretty frequently, and sometimes multiple times during a week. If you're doing that for many months or a year, it adds up. It's sort of like having a mini period once a week, right? And then also, the other thing is that there are a number of women who may be premenopausal, perimenopausal, depending on what therapies, they may still be having very heavy periods, or if they have a gynecological cancer and fibroid tumors or something like that, then they may be losing blood. So does it make sense to all of you that these are the three really main reasons why cancer patients are potentially anemic? Awesome. Okay, moving along. Your patient with a hemoglobin of 9 grams per deciliter will receive 1 unit of packed red blood cells. You expect that once the transfusion is complete, his new hemoglobin value will be what?
10.
Yep, exactly, because we know that each unit makes your hemoglobin go up by 1 point. So if I had given him 2 units of blood, then I would expect it to be 11, right? What I can tell you is, normally speaking, when patients' hemoglobin is less than 10, it's not unusual for us to give 2 pints or 2 units of packed red blood cells, because what'll happen is, if you don't kind of overshoot a little bit, you may end up having the patient need to come back the next week or come back more frequently, and we know that that can become an issue. So, for example, if I have a metastatic patient and his hemoglobin is 9 grams per deciliter, I'll probably give him 2 units of packed red blood cells, again, depending on his risk factors and some other things. And then I'll transition him to EPO or DARBO, whatever, to kind of help maintain that. So what's nice about transfusions is they immediately deal with symptoms. They make people feel better really, truly instantly. And then if they're metastatic, it allows us to start the question of being able to continue them on an ESA, if that's appropriate for them. Any questions on that? Awesome. So your patient refuses any blood products for philosophical reasons. This actually happens quite a bit. So what strategy can you use to prevent anemia? So dose reduction of chemotherapy, frequent blood draws, withholding chemotherapy, or pediatric tubes? Which one do you guys think is appropriate?
Ped tubes.
That's right. Yeah, because what we're doing is we're reducing the volume of blood that we're taking out from someone. Dose reduction of chemotherapy is only appropriate if someone's having a toxicity. Otherwise, we're potentially interfering with a person's outcomes if we're dose reducing. So this would really not be appropriate unless the patient cannot tolerate the dose that they're on. Frequent blood draws does the opposite. right? We're just taking more blood. And usually when we do phlebotomy for cancer patients, we're probably taking, anywhere from 10 to 20 mLs of blood. It just depends on how many tests we need to run. Withholding chemotherapy, that also is not a good idea for the same reasons I enumerated with dose reduction. We only want to withhold chemotherapy if a patient says, I'm done. I don't want any chemotherapy right now. They need to go on a holiday. We call it like a treatment holiday, or the patient's having unacceptable toxicities or progression. Then we can say, okay, you know what, we'll go ahead and withhold chemo. But as a mitigation strategy for someone who's refusing blood products, that's not going to be one of our ethical choices. Any questions on that? Cool. So Katie is a 46-year-old receiving adjuvant chemo following surgery for stage 3 colon cancer, but is otherwise healthy. She's receiving FOLFOX and has 3 more 14-day cycles. Her hemoglobin is 11 grams, and she's complaining of some fatigue, but no syncopal events or inability to perform most ADLs. Choose the most appropriate regimen for Katie. So what would you guys suggest? Do you want to initiate DARVA? No. Right. Do we want to change her chemo?
No.
No.
Nope. Do we want to recommend a transfusion?
No.
Why don't we want to recommend a transfusion?
Patient is just fatigue. Otherwise, there is no other symptoms.
Right.
And there's hemoglobin is 11.
Exactly. I mean, with a hemoglobin 11, she may be anemic, right? Because based on the guidelines, it's equal to or less than 11 grams per deciliter, or 2 or more grams per deciliter drop below baseline. But the important thing here is we see that she's otherwise healthy. That's super important, right? Because in the guidelines, we know that your risk stratification is categorized based on, do you have COPD? Do you have an underlying heart condition? Are you at risk for having maybe acute heart failure or something like that if you become decompensated? So in this case, yeah, she's anemic. I'm going to watch this. She's complaining of some fatigue, but she's not letting me know that she's overly symptomatic. Fatigue is very common from chemo. I would say probably 100% of my patients truly will complain of some amount of fatigue. And it doesn't even matter if it's immunotherapy or not. It doesn't mean that it's bad fatigue, but still most people will say, yeah, I'm a little bit tired, especially after treatment. So the most appropriate option for her would be to observe and maybe evaluate in 2 more weeks. Now, at this point, if she gets down to like 9, then maybe we have a little different conversation. She could still be asymptomatic at 9, but at 9, I don't have anywhere else to go but like really low. And so I might consider going ahead and giving her 1 or 2 units at that point. And usually when people get to about 9, they'll start complaining. I have had patients before, especially with some of the myeloid malignancies, I've had patients who've had hemoglobin of like 6.5, which is not really compatible with life. And I've had them bounce in and seem normal and have absolutely no symptoms or anything. So that's not necessarily common, but it does happen. And so, usually when that happens, we just say, well, I'm really glad you feel great, but you're going to need to have some red blood cells because 6.5 is not safe, right? Because your oxygen capacity, carrying capacity, decreases dramatically. And your kidneys get 25% of your blood supply. Your kidneys need oxygen, your brain needs oxygen. So in order to make sure that someone is perfusing properly, we want to give them transfusions when we need to. Any questions about that? Rock on. Okay. Oops. Sorry, I keep getting all these emails. I'm actually going to turn off my email. Nobody tell. Okay. Here we go. All right. So which of the following ADRs can be associated with ESA use? Select all that apply. So what about hypertension? Yes or no? That's right. What about increased triglycerides? Yes or no?
No.
Nope. What about tumor progression, potentially?
Yes.
Yes. And this one is super up for debate, to be honest with you. Like, we've been fighting about this in oncology for probably about 10 years or so. There's really no complete answer, but at this point, we know that we have vascular endothelial growth factor blockers, right? Like, so like Avastin, things like that, because we know that tumors love blood. So it makes sense theoretically that this could be an issue. So we go ahead and just assume the tumor progression is possible. What about an MI? And why are they at risk for an MI with an ESA? What is an MI?
Blockage.
Clot, so thrombotic risk.
Exactly, right. So, we talk about thrombotic risk factors in patients, or the risk of thrombosis. And, they can occur in any deep vein. It can occur in the lungs, but it's not uncommon for someone to have an acute myocardial infarction or have a thrombosis in one of the veins leading to the heart. So, and this is the one that we worry about the most, right? Because PEs are very dangerous, but they usually have some symptomatology before patients fully decompensate. And it's a little bit easier. We can get them in, do a VQ perfusion scan quickly. What am I trying to say? The presentation of a PE is usually a lot more predictable, right? So people will have a cough, they'll cough up blood, they may have chest tightness, difficulty breathing, a temperature. But for an MI, we know that women and men often have very different presentations. And so this is a much more dangerous event. We also know that hypertension can potentially lead to MI as well. So, all right, any questions on that? Rock on. In a cancer patient receiving palliative care for metastatic disease, the use of Procrit is preferred over a transfusion when the patient is both anemic and severely symptomatic. True or false? I can hear the hamster wheels going. That's right. False. Why?
Wouldn't they need packed red blood cells if they're severely symptomatic?
Exactly, because the last thing we want to do when someone's symptomatic is put more pressure on their heart. So in this case, for a patient, I'm going to do both, right? I'm going to give them transfusion, get their hemoglobin up to a level that's good for them to make them feel comfortable and have the symptoms reduced. And then I'm going to start them on something, especially if this happens more than once, or if I anticipate that it's going to continue to happen. And that's where some of the nuance comes in, right? Because it's like, well, I can give transfusions, but when do I start an ESA? And so for these particular patients, we're going to do it based on projected continued loss of hemoglobin. So if I think like, I think this was just a one-time event, we're changing the patient's chemo, or we're going to stop chemo and they're just going to get some other kind of palliation, then I might not necessarily give them the injections. But if I know that either their cancer is making their bone marrow dysfunctional, or I know that they're going to need to stay on therapy to make them comfortable, then I'll definitely transition them to something like Aranesp or Procrit to make sure that they stay comfortable. Any questions about that? Isn't this a great topic? It's so straightforward. It's one of my favorites. Unlike nausea and vomiting, which has like 1,000 permutations. Okay, as anemia worsens in cancer patients, younger reticulocytes are released from the marrow and can give a falsely what RI value? That's right. Yep. Because it looks as though you've got plenty of red blood cells, right? But in fact, they're only immature. And so we know that that's a function of worsening anemia. Okay. RT is a 53-year-old receiving adjuvant chemo following surgery for stage 2 breast cancer and has COPD. She's receiving Taxotere Cytoxan every 21 days for four more cycles. Her hemoglobin is 10.5, though she's complaining of mild fatigue, but otherwise fine. Choose the most appropriate regimen for RT. So what would you guys recommend?
Transfusion.
Yeah, and why would you recommend a transfusion?
Because she has COPD. She's It's like borderline anemia.
Exactly. So she is anemic, right? Because her hemoglobin is less than or equal to 11 grams per deciliter. Although, we don't know what her baseline was, right? It doesn't matter though, because 11 is kind of the cutoff. Once you are at 11 or drop below 11, we start to worry about you. Because she has COPD, she's definitely eligible for a transfusion. Why wouldn't we want to start her on EPO?
Because she's stage 2 breast cancer, so they probably are doing curative therapy rather than palliative.
Exactly. And that was really one of the big takeaways I wanted you to get from this, module is like, we don't just use ESAs for everyone. Now, if this patient had been a Jehovah's Witness, for example, or refusing to have any kind of blood product, that would very much change this conversation. So then we would have to say to her, okay, you're not symptomatic, but you're at risk. So we're going to need to initiate EPO, but I want you to understand that if we do that, we are potentially impairing the ability of the chemo to cure you, because it can potentially increase tumor progression. So, one of the things I want you to be able to do is if she were refusing blood products, I want you to know that you would initiate EPO. Okay? Because she's still high risk. So if she weren't high risk and she had no symptoms and she were refusing blood products, I would probably observe and reevaluate. And I might, for her, do it in 1 week, maybe not 2. But I'm not going to hold you to how do I guess? It's kind of arbitrary and it's based on the patient, in front of you and how they're doing. Does that make sense? Excellent. Okay, PA has stage 4 prostate cancer and is receiving palliative chemotherapy to decrease the severity of his bony metastases. His hemoglobin dropped to 8.5 grams per deciliter, and the team felt it was appropriate to initiate Retacrit. After 10 days, PA's hemoglobin is 10 grams per deciliter. What is the appropriate action to take? So what would you guys want to do?
Reduced by 25.
That's right. What is Retacrit? Is it Darbe or EPO?
EPO.
It's
Exactly.
EPO is an alpha EPBX.
Exactly. So it's just a biosimilar, right? Oops. Okay, so we're not going to continue it at the same dose because his hemoglobin popped up pretty quickly, right? In less than 2 weeks. So we definitely don't want to overshoot it and put him at risk for a thrombotic event. We're not going to withhold it because then he's going to just probably drop back down again, and then he's going to have this yo-yo. We're not going to decrease his dose by 40% because we would only do that for Aranesp and Aranesp related products. All right, does everybody get that one? We're good? Okay. So for patients who have concomitant iron deficiency and iron supplementation is required, which of the following iron preparations requires a test dose prior to administration? So
above.
That's right. Which one does?
The iron dextran.
Exactly. So iron dextran always, 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 always. There's never a caveat. You must do a test dose because iron dextran has a very high risk of reaction, and the reactions can be quite severe. So normally what we tend to like to choose like iron sucrose, for example, or ferric gluconate, just because they're easy to administer and it's not hard to get them covered by insurance. The only caveat with iron sucrose is that we have to give multiple small doses, and so it eats up chair time. We usually give people about 200 milligrams at a time. There was a study where they infused 500 milligrams in some patients who were Jehovah's Witnesses who were refusing blood products, and they infused it over like 4 hours or whatever. And there were some ADRs, associated with that, like more hypersensitivity, but it was considered otherwise pretty safe. So that's an option too, especially if the patient needs rapid iron repletion and they don't want to come back for multiple visits, because the 200 milligrams, it's like you do Monday, Wednesday, Friday, and then you try and get equal to about a gram. So that's a lot of visits. Does that make sense? Awesome. Were there any other questions before I close this down?
So none of the above will be the answer for number 10, right?
Correct. Yes, none of the above. Right.
I want to double check. Answer for number 4 is observe and evaluate in 2 weeks.
Yep.
Yeah. I answered what we discussed right now. And I got 90% as a score. I don't know what I missed. Probably I did miss something or I didn't. I'm pretty sure that what we discussed right now, that's the answer I picked during the quiz.
Okay. Yeah, I can take a look I may be able to look to see what your individual answers are, although I think normally it just drops the grade in. But I'll see what I can do.
Okay. Not right now, but I just want to know. I don't care how, but I just want to know what I missed. I think I chose the same answer, but I just want to know.
Sure. If I can, yeah.
You can do it in your own time. It's okay.
Okay. Yeah, I'll see if I can do it, because they may not allow me to go in and see individual answers, but I'll see what I can do. And if not, I can get Dr. Fox on it, because she's my tech guru.
Okay. Thank you.
Yeah, and of course. All right, cool. So, I think I'm going to stop sharing this for a second here. Okay.